So after our last session, we left off after discussing preeclampsia and eclampsia, which really just left the UTIs aspect here, and then we'll go on to the complications of pregnancy. So right now we were looking at basically complications that occur kind of sort of during pregnancy, but these were more so just related to the fetus. Now we're going to be seeing obstetric complications of pregnancy where the fetus is usually not a normal fetus. So as you can see from the first topic, ectopic pregnancy. There were these two questions that we didn't really look at last time. So let's start from here and then we'll move forward. So first one here, very common topic, DIC. 36-year-old woman, so she's over 35. First pregnancy at 38 weeks gestation. Was brought to the emergency department due to sudden vaginal bleeding and severe lower abdominal pain. She had a prenatal course notable for diet-controlled gestational diabetes. Alright, so she had some gestational diabetes. An ultrasound at 20 weeks showed normal fetal anatomy and a fundal placenta. She has a 5-pack year smoking history. So whenever they write that in a question, I just highlight smoking. That's enough, right? So when you go back after reading the question, if that was relevant for any reason, maybe a cardiovascular question or respiratory question, then you can always just see the word smoking highlighted and you'll know what's happening. Her vitals show a high blood pressure, right? Fast pulse. Physical exam shows uterine tenderness and moderate vaginal bleeding. So that is a pretty big red flag symptom. She can deliver, right? It's not like it will be too premature, but it's not exactly time yet. She should stay pregnant for maybe another week. Digital cervical exam shows a 3 centimeter dilated cervix with the fetus in vertex presentation at 0 station. So we looked at what these numbers are supposed to look like a couple days ago when we were looking at the graph showing active versus latent labor. This right now is looking like she's not going to be able to deliver, because if she's supposed to be delivering, well, this isn't open enough for her to actually get a baby out. Fetal heart tracing shows 140 with accelerations and moderate variability. So accelerations, as we saw, mean that there's fetal movement, and contractions occur every 2 minutes and last for 20 seconds. So that we also looked at in the other graph just within the last few days. Urinalysis shows 3+ protein, which is really bad, indicative of really bad kidney function and could be related to her hypertension. She is at greatest risk for what complication? So at this point, what she's going through with the bleeding that is occurring is clearly an issue of placental abruption. So that's what's the answer here, abruptio placentae. This topic of abruptio placentae is a step 1 topic, which we've discussed already, right? So we looked at it earlier when we were in the step 1 book, that there's only a couple pregnancy complications that we learned in step 1, and of all of them, there's only one that causes bleeding, which is the first one, abruptio placentae, right? Where the placenta has kind of ripped open, and depending on how the rupture has occurred, left versus right, if it's the one in the right picture, you can see that the bleeding is actually going to come out. If it's the bleeding like this, then that blood is just going to stay in a hematoma inside. But you can see that the placenta has detached from the mom, so the baby won't be getting any more life support in a sense, and contractions, fetal movement, and all these other things are not going to be normal anymore. One of the key factors here was hypertension. She also had the other factor of being a smoker, right? So we highlighted both of those things. 5-pack year smoking history, has been trying to quit, which doesn't really mean much, and then blood pressure being really high, right? So all of those two actually are the primary big issues that put her at risk for abrupt placenta. And then she also has the gestational diabetes, which of course doesn't make things any easier, right? So one of the big problems there is just possible DIC, because now you have tissue factor activation. This is like getting a cut inside. When we get a cut outside, your coagulation factors are going to come and help you. But now you're kind of bleeding from the inside, and your entire immune system, your entire hematological system is going to activate. Abruptio placentae refers to retroplacental bleeding between the placenta and the uterine decidua that can cause placental detachment and vaginal bleeding. The retroplacental hemorrhage can cause lower abdominal or back pain, high frequency and low amplitude uterine contractions, and a firm, tender uterus. Her tobacco use and preeclampsia are important risk factors. The larger the area of placental detachment, the greater the risk of maternal complications like DIC, due to tissue factor released by decidual bleeding and hypovolemic shock, which she's approaching. Right, so her pulse is up. Soon enough, her blood pressure is going to drop if we don't do anything about it because she's going to go into full blown shock. Potential fetal complications include hypoxia, preterm delivery, and just fetal demise as well. Right, so the baby could just die. The mom can die here too because DIC is usually fatal to a mom if you don't do something about it. Right, so DIC, maternal shock, and fetal distress, life-threatening for both mom and fetus. Right, so this is a very high yield, very easy topic. Always, you can definitely rest assured this will be on your test. Just make sure that you can catch it. Generally speaking, even if you weren't able to identify that this is abruptio placentae, just the fact that she has vaginal bleeding and the fetus is responding in such a weird way, but she's not exactly ready to deliver yet, increases her chances of getting DIC. The other answer choices that must have been in this question were things that a pregnant woman probably could be at risk for, but not her per se. Her risk for all the other things, like whatever other answer choices there were there, right? You have to consider, okay, maybe answer choice B was also something that she could be at risk for, but what are the chances of that risk, right? Because that's how you're going to have to figure out between multiple answer choices that are all plausible answer choices. For example, another answer choice might have been that she can get a UTI. Of course she can, but what are the chances? A UTI is very irrelevant to this question, but it can happen. The vaginal bleeding is there, the open cervix is there, so of course, yeah, she could possibly get a UTI, but that's not the point of this question, clearly, right? Another answer choice could have been abortion, right? Now, abortion she is at risk for, but it can be prevented. Maybe the baby can be delivered C-section and just get it all out real quick, and the baby will live because the baby's not dead yet. Right? We can tell the baby's not dead yet because there's accelerations. So that means the baby is responding to the distress that it's feeling from the placental detachment. So we need to get the baby out. So abortion would not be the number one answer choice here, and so on. Let's look at the next question. So here we have another topic that we have to really know about pregnancy. Pretty commonly known, well-known topic, but in questions, of course, it can always be confusing. As you could tell from this question, 50% chose the correct answer of giving aspirin, but a quarter of the people chose the wrong answer of giving high dose folate. So what was up with this question? Why did this many people mess up? 34-year-old woman, second pregnancy, 14 weeks gestation, comes to the office for a routine prenatal visit. All right. She's feeling well, has no concerns, daily nausea and vomiting for the first few weeks of her pregnancy, but symptoms resolved 2 weeks ago, totally normal. She has had no pelvic pain or vaginal bleeding, great. She has not yet felt fetal movement, not so good, but understandable because the baby's not big enough yet. But this may be concerning, so I'm going to highlight that. Not yet felt fetal movement. 14 weeks pregnant, fetal movement by 14 weeks pregnancy. I don't know if that's supposed to be a thing really, because the baby's only gotten so big at that point. Her first pregnancy ended in a cesarean delivery at 30 weeks gestation due to breech presentation and preeclampsia with severe features. So when that happens in your first pregnancy, it is almost 100% is going to happen again in the second pregnancy also. So every doctor knows that, and that's what you have to understand from the sentence they gave you in that question right now. The breech presentation doesn't have to happen again, but the preeclampsia and the cesarean delivery is most likely going to be the same case scenario for second pregnancy also. She has no chronic medical conditions. That's also great. Her only medicine is a daily prenatal vitamin, and she has no medication allergies. Okay, excellent. She does not smoke, drink, or use drugs. Even better. Vitals are looking okay. Uterus is gravid and non-tender. The remainder of the exam is unremarkable. What's the next best step in her management? So now, if everything is going so well, then I didn't understand why you would want to pick high dose 4 milligram folate now, right? Folate was most necessary before she conceived and then during that first trimester. She's pretty much almost done with her first trimester. If anything, now she doesn't need high dose folate. Soon enough, by the second trimester, she could probably stop taking folate because the majority of the rapid development that the baby undergoes is in the first trimester. Right? In fact, the development rate is fastest when it was one cell becoming two, becoming four. That's the most rapid, right? Because you have to think about it in percentages. One cell becoming two is 100% growth. Two cells becoming four is another 100% growth. That every time it's doubling, that's an increase by 100%. So if you're thinking of it in that manner, that is a very rapid growth. Eventually you get the blastula and the morula and all of that, and then boom, you have a body layout with polarity. Now you're not going to have 100% growth. Now not every cell is dividing by two anymore. That stops, right? There comes a point where the doubling of cells stops. Now you have a layout, you have a whole body, and now there's going to be extensive development of the nervous system and the other organs. Those are all things that are happening in the first trimester, which is why the first trimester is where you are most susceptible to teratogenic damage to the baby. And it's also where you need the most folate. So this answer choice made no sense to me. Right? When I see some of these answer choices that most people chose, I try to determine whether or not it was respectable. Right? Was it respectable that 25% of people chose to give her folate at this point? That's not respectable. It doesn't make any sense whatsoever. This isn't even medical knowledge. Any woman who's gone through any pregnancy would just know that. And elders that have been through multiple pregnancies would also be able to tell you this. Low dose aspirin, although you might not be able to figure out why she needs it, low dose aspirin is something you can give to anyone. Remember that aspirin, I believe, is still the #1 most ingested medicine in the world. Right? Everyone takes aspirin, and after a certain point in our lives, all of us will be taking aspirin every day. It's a normal thing to do. It's very preventative. It's very good preventative medication, and it's very helpful. So it was a safe answer to go with. I obviously don't have the other answer choices here, but there were probably other answer choices that we could do with her, other management things we could do with her that most likely weren't necessary. So here's why you needed aspirin for her. Preeclampsia, which she has a history of in her first pregnancy, is a leading cause of maternal and fetal morbidity due to the high risk of stroke, placental abruption, and DIC. Patients with predisposing factors like chronic kidney disease, chronic hypertension, and preeclampsia in a prior pregnancy, like in her, are at high risk. In high-risk patients, daily low-dose aspirin is the only therapy proven to decrease the risk of preeclampsia because it inhibits platelet aggregation and helps prevent placental ischemia. Preeclampsia likely results from abnormal vasoconstriction and increased platelet aggregation. It is started at the 12 to 28 weeks gestation, but optimally before 16 weeks gestation, and continued daily until delivery. We do this to hope that she won't have another preeclampsia moment in this second pregnancy. Right? So every time you see G2 or anything other than G1, right, meaning that this is not the first pregnancy for this person, then you always want to see what happened in the first pregnancy. Was everything okay? Because whatever happened in the first pregnancy, there's an extremely high chance it'll repeat itself in this second pregnancy, right? So that's something that we need to see, and we of course learned it when we covered the treatment yesterday of things that happen during preeclampsia. Right? We saw treatment delivery is the only cure. Closer term preeclampsia, induced delivery, get the baby out. Right? If you're far from term, just take care of the mom the best you can. Right? And then of course IV magnesium for any signs of possible seizures, which would then be considered having eclampsia. But you could tell that here, and of course even the remaining portion down here, there's really no mention of aspirin. Right? They're not teaching that in the book, which is why this question is appropriately placed here. I mean, we know that aspirin is used for all these reasons, right? We know all the reasons we use aspirin for, but it's not something that's mentioned in the book. So if you've never, really actually learned that, there was no real way for you to know. Even in the next topic of eclampsia, they don't really mention giving aspirin, to a pregnant mom to prevent preeclampsia in the next pregnancy. It's not really in the book. So that's kind of disappointing that it's not in the book, but that's why this annotated version is so much better. Right? So having this here, it'll tie up the one remaining factor they didn't teach. Preeclampsia prevention. Right? New onset hypertension and proteinuria plus end organ damage at more than 20 weeks gestation is preeclampsia. High risk all these other issues, well, she had this one, right? Any other question can occur. You could get another question where a mom has chronic hypertension. Remember, we looked at this before, that chronic hypertension is hypertension irrelevant of the pregnancy. This is a mom that had hypertension before she got pregnant or hypertension before 20 weeks gestation. Right? That's chronic hypertension. That means that after 20 weeks, she's still going to be hypertensive, right? Most likely. So that's preeclampsia. So the chronic hypertension can become preeclampsia. And of course, other risk factors of hypertension in general. So what do? Low dose aspirin at 12 weeks gestation all the way to delivery. And that's not in the book. So very good piece of information right there. Now, the next topic here was urinary tract infection and pyelonephritis during pregnancy. Asymptomatic bacteriuria occurs in up to 7% of pregnant women, and 30 to 40% will subsequently develop a UTI or pyelonephritis if untreated. Persistent untreated bacteriuria places the patient at a high risk for preterm labor, low birth weight, and perinatal mortality. E. coli is the main culprit here. Asymptomatic bacteriuria, if you have a patient, this is how they're going to present. Asymptomatic bacteriuria with a positive urine culture on the first trimester screening. A lot of colonies. They're going to have, if they have a UTI, they're going to have dysuria, urinary urgency, and frequency, which is often hard to identify because pregnant women, as we discussed earlier, already urinate more than normal anyway, right? Because the big uterus is sitting on top of the bladder. So as soon as the bladder fills up, there's no space for the bladder to expand. The heavy uterus is going to compress the bladder downwards when the mom stands up, and she's going to need to pee pretty much every time she stands up. So the urinary frequency part and urgency part would be pretty normal in most pregnant women, but not the dysuria. And then pyelonephritis, if they have pyelonephritis, it's going to present the same way. Plus, they'll have fever and costovertebral angle tenderness. The ureters are going to be tender, right? That's why it's costovertebral angle. So what do you do to diagnose this? Very simple. If we're talking about urinary tract infection, check the urine, right? And then that's going to give you the answer. And you treat based off of what you found in the urine, right? So 3 to 7 days, asymptomatic bacteriuria and UTI, you do 3 to 7 days of nitrofurantoin. This is the best answer choice to pick. However, you should avoid it in the first trimester if possible. Most women who present with urinary tract infections, it won't be in the first trimester. Because in the first trimester, most things are still normal in terms of the mother's anatomy. It's later when the baby starts getting bigger that the mom's anatomy changes and all the organs start acting weird. Right? That's when the mom is more at risk. But in the first trimester, you can't do nitrofurantoin. But later on, nitrofurantoin is usually the correct answer to pick, not these other guys. However, they all work, cephalexin and amoxicillin clavulanate. And then after this is done, right, you should follow up culture at 1 week to test for cure, right? Just to make sure. So this is usually a tricky answer choice you have to make sure you pick. Right? Just because you gave the antibiotic doesn't mean that everything was fixed. So once it's done, once the full course is done, you should check again. If the mom has pyelonephritis, then she needs to be admitted. That you don't send them home. You admit them, give IV fluids, IV third generation cephalosporins, suppressive antibiotics with agent culture susceptible for the remainder of pregnancy, and follow-up culture. Right? Because this is much more dangerous than just having asymptomatic bacteriuria and UTI. Pyelonephritis can just keep ascending and cause really bad kidney damage. Right? So you don't want that. Asymptomatic bacteriuria and UTI, very unlikely that they'll cause kidney damage, but they could proceed and make things worse eventually. So, you deal with it before it becomes symptomatic, of course. Right. So that's really all this question is about. If you do get a question on this, it's usually going to be very clear, right? Because a pregnant woman should never have fever. So the fever part is going to make pyelonephritis really easy. And a pregnant woman's urine can only have a few things that are out of the ordinary, as we already saw. So earlier, actually, let me see if it was earlier or is it coming up? No, it was earlier. So earlier, when we were looking at things that are normal in pregnancy, we saw, so remember that in the beginning of this book, I have all these questions of things that are normal in pregnancy, right? And then there was this question right here, pyelonephritis in pregnancy. Right? If we revisit this question now, we'll see that there was something very confusing here that a lot of people fell for. So you have to figure that out by yourself. Uh, well, not by yourself anymore. Now you have me, but in a question when you're sitting on your real test, you have to figure it out by yourself. 19-year-old Primigravida comes to the ED for evaluation of right-sided abdominal pain and fever for the past 2 days. So already you see that pain has progressed over the last few hours and is now unbearable. She's had increasing fatigue, nausea, and anorexia, but no vomiting or diarrhea. She has had some non-painful contractions, but no vaginal bleeding or discharge. She has had no prenatal care and is at 24 weeks gestation by date of her last sure regular period. She has no chronic medical conditions, no prior surgeries, doesn't smoke, drink, or do drugs. Vitals are showing the fever, high pulse, tenderness over the right flank. So that right there was enough for you to know that the right flank, they're talking about the right ureter, that's pyelonephritis. With no abdominal rebound or guarding, the uterus is non-tender, cervix is closed, amniotic membranes are intact, everything's okay. All she has, everything is literally okay. We see that, right? She has contractions, but they're not painful. They're normal contractions she's having. Why is she having contractions? Because she has a fever and the baby's noticing that, right? So the baby's responding. It's a distressful response from the baby. But the right flank part, as you're reading the question, you highlight that, you see it, and then you're done. You know, what is the most likely diagnosis? You look at your answer choices, you see acute pyelonephritis, it matches everything we've highlighted, you're done. Intraamniotic infection was not the right answer choice. Intraamniotic infection inside the amnion would not cause right flank pain. If the infection is inside the amniotic fluid area, that's just going to really mess up the baby, but not going to cause right flank pain. Why would there be right flank pain? So the flank pain stuff is going to be your number one indicator of pyelonephritis. The rest of that is explained over here. Intraamniotic infection would present similarly, but this is a diagnosis of exclusion, and her flank pain makes acute pyelonephritis more likely. Right? Plus her non-tender uterus, closed cervix, intact membranes, everything being okay makes intraamniotic infection very unlikely. Right? You have to remember that intraamniotic infection is basically fetal infection, and at that point the baby would really be distressed and would want to come out. But the baby's not wanting to come out. Non-painful contractions, everything's okay. Everything's intact. So pyelonephritis is pretty commonly tested. There's also this question here, right? Physiologic hydronephrosis of pregnancy, things that are normal, where you needed no additional management, right? Nothing needed to be done. And then we've already looked at this question. We understood that there's a uterus that's really big, and that's kind of going to be compressing the uterus, right? This big baby not only presses down on the bladder, but the two tubes, the two ureters coming out of the bladder can also be squeezed and compressed, causing fluid to urine basically to back up, leading to hydronephrosis. Totally normal. Nothing needs to be done. You know, it's going to be fine when the mom is moving around, the mom is walking, the mom is turning in bed. Things will be okay. Right? So these first few questions that I added into here of all the things that are normal in pregnancy, and then how to see things when they're not normal in pregnancy, were critical, right? Very critical. So you can always be confident in picking the answer choice of no management, right? Reassure, everything's okay. And then of course we learned all the fetal heart rate, non-stress tests, and stress tests, and all that stuff. And again, if you haven't yet mastered it, you just go ahead and revise it again. Antepartum hemorrhage, any bleeding that occurs after 20 weeks gestation, complicates 3 to 5% of pregnancies. Bleeding is never a good sign, as we just saw in our earlier question right here, that the bleeding was here, a sign, in this one actually, a sign of possible DIC, possible abruptio placentae, which right here they're talking about. The other causes include other forms of abnormal placentation, but generally speaking, you know, if you have bleeding, then that's gonna cause accelerations in the baby. The baby's heart rate is gonna go up due to distress. It's gonna cause potential need for delivery, because if the placenta has detached, the baby's no longer gonna have life support. And it can cause a lot of things in the mom. One of the most common things that occur in the mother due to excessive bleeding was Sheehan syndrome, right? So we've seen that in step 1, where you get a pituitary infarct because there wasn't enough bleeding, there wasn't enough blood circulation in the body to bring blood to the pituitary gland. So you get Sheehan syndrome, right? So that's all that topic is really about. This isn't necessarily a topic, but just something for you to keep in mind. With third trimester bleeding, this is a nice key fact here. With third trimester bleeding, think anatomically: vagina, bloody show or trauma; cervix, cervical cancer, cervical vaginal lesion; placenta, you would have placental eruption or placenta previa; or fetus, fetal bleeding. Fetal bleeding is extremely uncommon, not really a thing. I've never seen a question on fetal bleeding, but anatomically, yes, if the blood is inside the amniotic sac, then yeah, it must be fetal bleeding. But again, not really a thing that occurs. The fetus is very unlikely to bleed. So next thing, huge topic, another step one revisiting, ectopic pregnancy. Right? We had this all over step one. This was a huge topic in step one. Most often tubal, but can be abdominal, ovarian, or even cervical. Presents with unilateral lower abdominal pain and vaginal spotting, bleeding, although some patients are asymptomatic. Only until the baby starts getting bigger or the woman doesn't have her menstrual period and then she realizes that something's wrong. Associated with etiologies that cause scarring to the fallopian tubes, including a history of pelvic inflammatory disease, pelvic surgery, using diethylstilbestrol, or endometriosis. Differential diagnosis includes surgical abdomen, abortion, ovarian torsion, PID, and ruptured ovarian cyst. There's a lot of differentials actually because they all kind of tend to present the same way. But one of the key things to know compared to some of these is that beta HCG won't be present in them. Right, like if you have a surgical abdomen, there should be normal menstruation. Ovarian torsion, pelvic inflammatory disease, ruptured ovarian cyst, most of these should be having normal menstruation. Right, so that's one of the key things. In an ectopic pregnancy, beta HCG will be high, and periods will be missed. So that's kind of how you figure it out. Another way to figure it out is usually a very young person, someone who must have most likely been having unsafe sex and didn't really practice safe sex enough to realize that they got pregnant, right? So one of the key things we learned in step one was this thing here, right? How all this occurs, basically a med school topic. So something that can happen is that we need to realize there's no connection right here. There's no connection from the ovary to the fallopian tube. It's not like this is sitting in here. So in between this open space is just a lot of open space. It is just by sheer chance and luck and function that when ovulation occurs, that little ovum actually goes in here, gets sucked into here, and then by the peristaltic movement of the fallopian tube makes its way through. Right? It can happen that sperm would make all of its traveling down to here and cause pregnancy out here. Right? It is a thing that can happen, which there are questions on, very commonly tested, very uncommon in real life, but very commonly tested. So if sperm made it all the way through the fallopian tube, made it into this open area, and then ovulation occurred and it fertilized it in this open area out here, then implantation can occur anywhere out here, or may not even really occur, and then the baby would actually start developing. And that's really bad because now the mom is going to die bleeding to death. Because this area, there's no way it can handle the growth of a baby. Right? So that's going to be something really problematic to kind of keep an eye out for and watch out in questions. Let me see if there's anything else here. Ectopic pregnancy. There was right here. So ectopic pregnancy, we're looking at pregnancy complications step 1, which is what we're looking at, pregnancy complications at CK. So here you can see implantation of the fertilized ovum in a site other than the uterus, most often in the ampulla of the fallopian tube. Suspect with history of amenorrhea, which is the #1 key symptom here. They don't have menstruation anymore. Lower than expected rise in HCG, so they'll have HCG, of course, which is why they're not having menstrual cycles, and that's how you know they're pregnant, but it's an ectopic pregnancy. How do you know it's ectopic? Because HCG is supposed to be actually doubling in the beginning, right? The first week. But it'll be lower than expected rise in HCG based on dates. Sudden lower abdominal pain. You just do an ultrasound. Very simple, right? Of course. Anything related to pregnancy and a fetus is always ultrasound. Often clinically mistaken for appendicitis. unless it's on the other side, right? Unless the ectopic pregnancy occurred on the opposite side. So that's kind of all there is to that. They go on to then talk about it right here. Diagnosis: approach a woman of reproductive age presenting with abdominal pain as a ruptured ectopic pregnancy until proven otherwise. Right? Any time you get a young woman with abdominal pain, right, you start thinking, okay, maybe she's pregnant, and then you order an ACG, and that's obviously the best thing to do. So here they tell you that the best initial test is a transvaginal ultrasonogram showing an empty uterus, right? But to me, that doesn't really make sense. The best initial test should be to just order a beta ACG. This way we can first see whether or not she's even pregnant, right? It's a theoretically an easier test to do, in my opinion. But you have to go along with what the book is teaching, and of course with what you're going to see in questions. So don't get messed up on that. Don't get caught up. You're going to have both answer choices there. Right, but apparently first thing you should do is do the ultrasound to see that the uterus is empty, then order a beta ACG test to stratify patients where transvaginal ultrasound is non-diagnostic. Right, if beta ACG is more than 1500, repeat the beta ACG and ultrasound again in 2 days to see if it appropriately increased. If beta ACG is less than 1500, then keep doing beta ACG until levels reach 1500, which is when an intrauterine pregnancy should be seen. 1500 IU per liter is when you know that implantation has occurred. Right? So that's not going to occur, and then that's kind of when you start thinking, all right, yeah, it's definitely an ectopic pregnancy, and we need to figure out what's happening. So here we're seeing normal intrauterine pregnancy and ectopic pregnancy. Ultrasounds are on CK. You're going to get these images. You probably won't have any idea what you're seeing. And even though they're teaching it to you a little bit here, you probably still won't know what you're seeing. It's going to be a very difficult thing. So in image A over here, they're showing transvaginal ultrasonogram of a normal intrauterine pregnancy with a gestational sac containing a yolk sac within the uterine cavity. Right. So these X's are to mark that that's the extra space around here. Right. So from here to here is empty space, and it's nice and clear. From here to here is another empty space, and the yolk sac is inside. And this is the yolk sac right here. Okay, tiny thing right there. And then the rest of it is a gestational sac, and it's all implanted. All right. The thing you see here is a little different looking, right? First of all, it's not nice and clear. The rest of this area doesn't look nice and clear in this one, and that can happen if you're shaking the ultrasound device too much. It can look like this. What's really key here is this endometrial stripe that you're probably not really gonna find. You know, if you see it, then great. But to be entirely honest, if that label wasn't there, so let me show you what it looks like if that label is not there. If this line wasn't here, oh wow, they have it already on the graph too, so I can't move it. I don't know why they even put another line on top if it was already in the picture. But if this line wasn't there, then you wouldn't really see it. It all starts looking the same. Everything just blends in. You know, this white line really pointed out the endometrial stripe here. In ultrasound B, you're seeing a complex mass, CM, ectopic pregnancy adjacent to an empty uterus. That's apparently what you're seeing here. You know, but again, this is not the best thing for us because we're not extremely trained on understanding what ultrasounds look like. So if you have no experience with this, you're going to be pretty lost, you know. But you have to use your best clinical judgment based off of what else is given in the clinical scenario of the question and what they must be trying to show you. You know, that's kind of what you work with. They go on to then say treatment. Just do medical treatment with methotrexate, sufficient for small unruptured tubal pregnancies. So if it's early enough, you could do this. If it's not early enough, then surgical options include salpingectomy or salpingostomy with evacuation. Right? Some things that can go wrong here. Well, abortion never is flawless, so tubal rupture and hemoperitoneum can still occur. Hemoperitoneum is an obstetric emergency that they love testing you on. And one of the number one things that causes hemoperitoneum is actually what I was telling you guys here, that you get a pregnancy out here in this open area. That is going to be really bad. That's going to be peritoneal bleeding. and you can't stop it. Can't stop that bleeding. All right. So let's take a look at what else is here. The other thing that's on this massive page right here is the three main guys, right? So the three main guys we just looked at with pregnancy complications in step one: the placenta eruption, morbidly adherent placenta, which is too strongly attached, and then placenta previa, right? So they have placenta eruption, placenta previa. Oh, they don't even have the morbidly adherent one. They have vasa previa, which is this next topic over here. Vasa previa is not that complex at all, but the morbidly adherent thing is a little more weirdly tested because there's three levels of it: accreta, increta, and percreta with the morbidly adherent placenta. Each of those words is related to how strongly the placenta is attached to the mom. It's a huge issue because normally the placenta will detach and the placenta also comes out with delivery. Now it's not going to detach. And if you try detaching it, you're going to rip it out of the mom, which of course puts the mom once again at risk of bleeding to death and having DIC. So those are some really problematic issues. No separation of placenta after delivery, leading to postpartum bleeding, which of course can cause Sheehan syndrome. And the same bleeding can also cause DIC and many other issues, and she can die. Right? So attaches, invades, and perforates. That's accreta, increta, percreta. Right? The other topics, not so bad. So we can come back to it after we look at some of these questions first. So first thing here is this workflow of management of suspected ectopic pregnancy, which we just looked at right now, right? Diagnosis, treatment. So let's take a look at what's happening with this. So first of all, you can already tell too young, right? 15-year-old girl comes to the emergency department due to nausea and lower abdominal pain. So as soon as you read that in a question, as soon as you get a patient like this, first thing you think of is asking her, is she sexually active, right? That's something you have to understand. You're going to get questions of ethics, right? Ethically speaking, if the question is an ethics question, if they ask you what is the best thing for you to say first, you should ask her, are you sexually active, right? Because that is something that needs to be clarified. And the way this will be tested in an ethics question is that this girl may have come with her parents. So you would have to ask the parents to step out and then ask her, right? If at that point the parents deny to step out, right, then it becomes a medical emergency where you're going to have to do something that is probably a little drastic, and you would have to pick what sounds most logical from the answer choices. Because if you get a 15-year-old girl coming in with nausea and abdominal pain, and her parents don't want to leave her alone, then she's not going to be openly willing to talk to you about the fact that she is sexually active and may be pregnant, right? Because she's of course scared with her parents there. But then that puts her at risk of just dying, right? Because this pregnancy, if it never gets resolved, it's just going to grow and she's going to get hemoperitoneum and everything is going to go bad. Or if she doesn't die, then the best case scenario is that she'll, of course, eventually have to get treatment and she'll be treated, but then she's going to have lifelong damage to her fallopian tubes or whatever, and she may never be able to get pregnant again. So both of those are extremely bad scenarios. Death, never get pregnant, right? So you don't need any of that. So the ethics version of these questions are pretty dramatic, right? Where oftentimes parents don't want to step out. I mean, as far as, I always reference things that I know about from my own culture. So most girls, right, in my culture, in the Indian, Pakistani, Bangladeshi culture, also in the Muslim culture, both of those different variations. And this is also seen in many other cultures, but I wouldn't know them that personally. This is seen in many of the Chinese, Japanese, and other Oriental cultures as well. It's seen in many things. But in my culture, a 15-year-old girl never goes to a doctor alone. So that is something that is extremely problematic because then many things often go overlooked. So when a 15-year-old girl does need to go to see a doctor, the mom will almost always indefinitely go with the 15-year-old daughter, and the mom will not step out and leave the daughter alone. So then at that point, you may need to go ahead and take things to the next level, where if the patient is looking like there's a really risky issue and the parent is completely denying to let the patient be their own person, you may need to call in authorities, right? You may need to do like a police thing at that point. But here, she's here alone. She's got this lower abdominal pain. First thing you should think of, she might have an ectopic pregnancy. Right? The pain began yesterday but has become worse over the past 12 hours. She describes the pain as crampy with periodic sharp and stabbing sensations. No appetite and vomited twice this morning, which should make you think of pregnancy even more. Right? Because remember, we said there's only two reasons we ever really vomit. Two reasons we vomit. Either because we ate something really shitty and we vomited, upset stomach, or because there's something in our brain that's kind of triggering the chemoreceptor trigger zone. And that second thing has many reasons, right? It could be an electrolyte or pH imbalance that's triggering the chemoreceptor trigger zone, or you could have a tumor, you could have elevated intracranial pressure, a bunch of other reasons in that second branch. But these are the only two branches that cause vomiting. She doesn't fit either one of those two branches because she's a special case of something rarely that occurs, ectopic pregnancy, right? She normally has menstrual cramping, but not usually this severe. So in the question, they're trying to trick you into thinking that she might have cramps and that she may be on her period, right? She started having vaginal spotting today. Normally has menstrual cramping, but not usually this severe. She has no medical history other than an episode of abnormal vaginal discharge 3 months ago that's self-resolved. So now they're really trying to make you think of weird things that may have occurred. But there's a story to paint here. If she had abnormal vaginal discharge 3 months ago that's self-resolved, that could have been gonorrhea that she never actually resolved. And if you don't resolve the gonorrhea, then that leads to pelvic inflammatory disease. Right? It could have been chlamydia also, either one of them. So self-resolving vaginal discharge is not a real thing. It's not supposed to self-resolve, right? Some vaginal discharges can, but the infection-related ones do not self-resolve. Menorrhea was at age 13 and her periods are irregular. Exam shows tenderness and palpation in the left lower quadrant of the abdomen. What is the most likely explanation for a condition? So tenderness on the left lower quadrant. It's usually going to be right lower quadrant, so they can confuse you into thinking like appendicitis or something. But it's all a perfect picture in this question. She has ectopic pregnancy. The most likely explanation: developing blastocyst implanted in an extrauterine location. Her history of vaginal discharge is suspicious for STI, which predisposes her to predisposes her to pelvic inflammatory disease, which will lead to ectopic pregnancy. Tubal rupture can lead to hemodynamic instability. Test for HCG, and if positive, do a transvaginal ultrasound immediately to locate the gestational sac. So you see in this explanation, they kind of wrote it the other way around, right? Test for HCG, and then if that's positive, do the ultrasound. But that's kind of inaccurate. Although this is how I usually think about it as well. As far as tests are concerned, that is inaccurate. Look at this to figure out how you would do this. And even here they have it the other way around. Here they tell you do the HCG, then do the ultrasound. So what is happening? Because then in first aid, right? In first aid they told you, where the diagnosis, approach the patient with the best initial test being the ultrasound, and then the next best test being the beta HCG. So it turns out, and as I've learned from most of these questions, especially UWorld, turns out that it is what we were thinking, right? Which is just to do the HCG. It is only logical to do the ultrasound first in very few case scenarios, but not the correct answer choice. So what your job is going to be when you start doing practice questions, especially other than the ones we're looking at here, so maybe another Q bank, would be to see what you are supposed to do first. But generally speaking, in all these questions, the correct answer will be to do the HCG first. Even though first aid is kind of mentioning that the best initial test is ultrasound, that's not looking like what is actually the case scenario. It doesn't really make sense. Why would you do an ultrasound? Do the HCG, then you know she's pregnant. Now do the ultrasound, and you don't see a fetus, then you know that she's got an ectopic pregnancy. Common sense. The other way around, if you do an ultrasound first, what's the point? Right? You don't know she's pregnant, so what are you even looking for? That's like doing an ultrasound on any other woman that's not even remotely sexually active. It makes no sense. So here they tell you, management of suspected ectopic pregnancy, the correct workflow is to first, of course, order the HCG. We need to see, is she even pregnant? Right? This is usually going to be further clear from a patient who has missed periods. Now, there might be other things there. Positive urine HCG, lower abdominal pain, which is in their presentation, and possible vaginal bleeding, like this patient had some vaginal spotting. Now, this rarely ever presents as hemodynamically unstable, But when it does, you need to do immediate surgical consultation, right? But the surgical consultation you don't order until you pair all of this together, or at the very minimum, you need to pair hemodynamic instability with a positive ACG. Then you know what's the story there, and you get surgery done immediately because they're hemodynamically unstable and they can die. But usually, like this patient here, they will be hemodynamically stable because if you missed your period 2 months in a row and you know you were sexually active, then you're definitely pregnant, right? And you need to come in, especially if it's all painful and weird, then it might be an ectopic pregnancy. So by that time, they do come in and they're still hemodynamically stable. So now that you saw the positive ACG, you do your transvaginal ultrasound. And when you do it, you may see an adnexal mass. That is an ectopic pregnancy. You get rid of it with methotrexate, or if it's too big now, then of course laparotomy and all that stuff. You may do the transvaginal ultrasound and see an intrauterine pregnancy. That's perfect. That's great. So she is pregnant, and that's okay. It's at the correct place. But you may do a transvaginal ultrasound, and it may be non-diagnostic. So this is where they were talking about in the book. This is what the first aid portion is talking about. So first aid was only talking about this segment. Right, this is the only portion they were talking about where you did the transvaginal ultrasound for whatever reason, right? So this is what first aid did. First aid mentioned A, and then B, and then C, like that, in the treatment portion right here, which was definitely very misleading for in the diagnosis portion right here. Very misleading, but they should have started from the very beginning, right? Very beginning. So very beginning was the way this workflow is showing you right here. Right, patient comes in, like this woman, this little girl, has abdominal pain, hasn't had her period, has some spotting today, and then you start noticing what's happening, and you go ahead and start thinking that all of this is telling you, especially the lower quadrant, left lower quadrant pain, is all of this is telling you ectopic pregnancy. What would be the next best step? So this question could be a multi-part question. So first thing was, what do you think is wrong? Well, she has an ectopic pregnancy. What's the next best step? Do a positive ACG test. Once you get the positive ACG, which is a very rapid thing, now you can go ahead and order a transvaginal ultrasound. You do the transvaginal ultrasound, you'll see the adnexal mass, and then you give the methotrexate, part 3. That's it. So here what we're seeing is when you get the first time a patient comes in, initial presentation, smells of ectopic pregnancy, that she missed her periods, has abdominal pain, is probably pretty damn young, may have had a history of infection like this girl, where she didn't get it treated very well, or they could try to trick you. They could tell you that she had gonorrhea and that she just took the treatment for gonorrhea. Remember that you're supposed to treat both things, right? She needed the doxy and the azithro because you need to treat for concomitant chlamydial infection as well. So that's another thing that can happen in a question. They could tell you that she had one infection and she only treated for one, not for both. That's bad. So any of those key things can occur. They're hemodynamically stable. You got the positive ACG. Then you go to transvaginal ultrasound. Now, if you did a transvaginal ultrasound and it was somehow non-diagnostic, then of course you come back to beta ACG now and keep monitoring beta ACG to see if it's rising appropriately. Right? If it is rising appropriately, she should be appropriately pregnant. At which point, this is the side you would come to, and you would just do the ultrasound again, and now you should eventually be able to find the intrauterine pregnancy. Right? If it's not rising correctly, then you keep checking ACG to see, how much is it rising. And if it's not rising appropriately at all, that she's got some kind of weird pregnancy. Could be a molar pregnancy, could be an ectopic pregnancy. You would have to keep, tabs on whatever else you find out about the patient to figure out what's happening. So although it's supposed to be an extremely simple topic, it can often become pretty confusing. So you got to be very careful with that. All right, this question was about... That's a previa, so we'll come back to that. This is also placenta previa, and then placental abruption, fetal chromosomal abnormality. Then we have a bunch of other questions and other things. I'm just looking to see if we have another ectopic question. No, we don't have another one. All right, so no more ectopic pregnancy questions, but generally speaking, just make sure you understand this workflow, right? Make sure you understand this workflow, and that depending on where in the workflow you're at in your question stem, you pick up from there. So in your question, this might happen, they may do this, then this might happen, then they'll ask you what's the next best step. Well, then it's this. So you pick that as an answer choice, right? That's kind of what we were seeing in first aid. That's probably where you're going to see most of your questions. But in this question right here, the one we're working with right now, we only saw that she had lower abdominal pain and some vaginal spotting, right? And she is hemodynamically stable. She's pretty stable. Her vitals are just fine. She's not dying. So then the next thing we need is to get the ACG also. Once we get all three things, we know she's got a pregnancy. We then order a transvaginal ultrasound. And then we hopefully find it and deal with it. So the next few topics: placental abruption, placenta previa, vasa previa, all from step 1, which we've kind of already talked about. Right? We looked at this. We just now looked at the morbidly adherent placenta. Next thing is placenta previa, which we've also seen questions of. Right? We get a preview of the placenta through the cervix. This we saw earlier when we were talking about whether or not you should do a contraction stress test or a BPP, biophysical profile. This is a case scenario where you would not do a contraction stress testing, because if you try doing contractions in this patient, you may end up actually expelling the placenta and causing vaginal bleeding, right? And cause early premature delivery. So none of that is a good idea. This is a case scenario where you do not order a contraction stress test. Attachment of the placenta to the lower uterine level, you can actually see it. Now, what do you do here? With this patient, we usually need a C-section because there's no way you can get this baby to be delivered correctly. Oftentimes, the baby may not even develop correctly, because we spoke about this a little bit, that normally if the placenta is attached where it's supposed to be, like this, then a lot of blood can come and a lot of supply can come from the mom, which then of course goes to the baby. But when you put it down here, this is placenta attached to the mom in such a place where not much is going to be provided. I mean, think about this one right here. This entire area is doing nothing. It's non-functional, because what am I providing here in this little portion right here? Nothing. Right? There's no nutrients to be provided, so the baby doesn't really get much. Right? And all of these babies with placenta previa need to be delivered early, and that's just what happens with them. So that's what we're going to see. And then the last thing here we're going to see in CK is vasa previa. So I've got extra pictures here, but basically what's happening in these babies is, instead of the placenta being at the bottom, we have the blood vessels being at the bottom, right? So fetal vessels run over or in close proximity to the cervical os. So you can see them through the cervix. May result in vessel rupture, exsanguination, which is bleeding to death, and fetal death, which of course all of it is really bad news. Presents with triad of membrane rupture, painless vaginal bleeding, and fetal bradycardia. Of course, the baby's heart rate goes down because the baby's not getting enough blood. Emergency C-section is usually indicated, frequently associated with developmentous umbilical cord insertion, where the cord inserts into the choriamniotic membrane rather than the placenta, leading to fetal vessels traveling to the placenta, unprotected by Wharton jelly. Right, so this is really dangerous. The developmentous umbilical cord insertion. We really don't want that. That is not a good thing. Right? The cord needs to be protected by the Wharton jelly, and that's why it won't be squeezed. The Wharton jelly is like a protective buffer. It's like an ocean with the tube just floating in there nicely, and the mom's pressure will never squeeze that vessel. We all know that a pregnant woman, especially with a really gravid uterus, when they lay on their back, that the big uterus can actually press down on the mom's inferior vena cava, really messing up blood flow, right? That can occur, but you'll never see a mom who actually can squeeze her own umbilical vessels, because they're protected by the Wharton jelly. They have a buffer around them. They're cushioned. That cushioning is perfect. Without that cushioning, you get all kinds of issues. So vasa previa is a really dangerous thing for the baby, and you need to get the baby out immediately, right? So here in this picture, we can see the you see your placenta, right? No longer placenta previa. The placenta is nicely in the side, not in the middle, not in this area here, right? But what is going on is you have this trifurcated umbilical cord, right? It's coming out in a weird way, and you can see the umbilical cord through the cervix, right? And it's going over the head, and then it's going into the umbilical area of the baby. It has a velamentous insertion of the cord, right? It's not protected by Wharton jelly. So of course it can be squeezed, it can be compressed, and it can rupture. Sometimes as the baby grows, the baby even grabs onto it. So that's also bad because naturally a baby's job is to grip. So they'll grip it and they'll squeeze it, and that's not going to be good. So vasoprevia is a really big test topic as well. As you can see all three of them here. The most common thing is just placental abruption. Extremely rare to have vasoprevia. Each of these has their own risk factors that you have to know very well, because those are the things that will be in the questions, hinting to you what the question is about, and then symptoms and how you diagnose it and how you manage it. So let's take a look at each one. So first one, placental abruption. Premature pathophysiology, premature separation of normally implanted placenta. Right? The placenta has now detached. So what are things that can cause the placenta to detach? Hypertension, abdominal pelvic trauma, a really bad fall, tobacco or cocaine use, previous placental abruption, rapid decompression of an overdistended uterus, and excessive stimulation. Right? All of these are things that can cause the placenta to just give up. So then you get painful, dark vaginal bleeding that does not spontaneously cease. And this puts the mother at risk for DIC. Abdominal pain, uterine hypertonicity, fetal distress. So fetal distress, how does this always present? This is going to present with accelerations. Right? Fetal distress is always going to present with accelerations, where the baby's heart rate is going up because it's like, what the fuck is happening? Diagnosis is primarily clinical. You could do a transabdominal or transvaginal ultrasound, but it's only sensitive in 50%. Look for a retroplacental clot, most useful for ruling out previa. Management, stabilize the patient with mild abruption and a premature fetus, manage expectantly, right? Hospitalize them, start IV and fetal monitoring, type and cross-match the blood, and give the mom bed rest. So the cross-matching of the blood is to make sure to see that the fetal blood and the maternal blood isn't going to kill each other. Mainly the mom's not going to kill the fetus. Moderate to severe abruption is more problematic. You need immediate delivery, right? Vaginal delivery with amniotomy if mother and fetus are stable and delivery is expected soon. C-section for maternal or fetal distress. So delivery immediately is a case scenario where things are okay. The mom's not like dying. But if the mom is not stable at all, you can't do this. So you would have to do the C-section, where the baby might still die, but you need to save the mom. Saving the mom is always the priority between the two, because the mom can make more babies. So that's one thing. And just because the mom is the primary patient here. Complications, of course, you can get hemorrhagic shock because you're bleeding out too much, right? Or you can get hemorrhagic shock is basically a type of hypovolemic shock, right? DIC occurs in pretty much all the patients, especially on step 1, 100% of patients. Recurrence risk is 5 to 16%, which is why it's really important. If it's occurred in the past, you need to keep that in mind. And of course, the fetus is not getting enough blood, so fetal hypoxia, the fetus can die. So most of this is pretty commonsensical now that we look at it. The only part that may not have been commonsensical was the incidence level, the fact that you're going to have fetal accelerations because the baby is still alive, and the fact that you would have to do the C-section if there's really bad distress and things are not going well. Okay, get the baby out. Next thing, placenta previa. So this is what we were kind of differentiating, ruling out. When you do the ultrasound, you rule out placenta previa. So placenta previa is a placenta that's pretty non-functional, right? It's placed in such a bad way that it's not really functionally going to be relevant. Okay. Abnormal placental implantation. Total, marginal, or low-lying, right? Different variations of it, as we saw in this picture right here. Placenta previa, right? This one is marginal, right? But it could be total, where total means that it's literally the whole thing is sitting right here, right? And then partial is this one, where majority of it is not sitting on the surface, but a tiny portion of it is, so that's pretty bad too. So total, placenta covers the cervical os. Marginal, placenta extends to the margin of the cervical os, and low-lying, placenta is in close proximity to the os. Right, so close proximity would be like something like this, where you don't see it, but it's there. Basically, if you put your finger in and try to move it this way, you would be able to touch the placenta, which is not how a normal placenta is supposed to be. right? So you got your three things. So complete, partial, and then far from it, but low lying. Low lying is not good either. This is pretty rare. Risk factors are prior C-sections, grand multiparity, advanced maternal age, multiple gestation, or of course another prior placenta previa. As I said, whatever happened in the previous pregnancy most likely will occur in the next pregnancy as well. So what do you see? Painless. Remember, big difference here. Abruption is ripping off of the placenta. Here, the placenta is there. It's trying to do its best job, but some blood is leaking. So you get painless, bright red bleeding that often ceases in 1 to 2 hours with or without uterine contractions. Usually no fetal distress because, as we said, the placenta is working. It's just not working that well, right? Here, in placenta abruption, the placenta is no longer working. It's not attached. And so that's a key difference, and that's painful because it ripped off. Diagnosis, you do the ultrasound, very sensitive. You'll immediately notice it that it's malpositioned. So what do? Well, basically, don't do a vaginal exam because you don't want to put your finger in there and then move the placenta and rip it off. Right? Stabilize patients with a premature fetus, manage expectantly, give tocolytics. You want to stop any contractions that are occurring because more contractions will just risk the placenta from ripping off. Serial ultrasonograms to assess fetal growth. Make sure everything is going well, even though the placenta is not at the right spot. And then this is a key answer choice that is repeatedly the correct answer choice. And we're going to see that in our questions. Betamethasone, which is a SON, just like prednisone is a corticosteroid. You need to give corticosteroids to help with fetal lung maturity, right? Especially if you're going to be doing early delivery, right? So you need to get the fetal lung maturity going as fast as possible. Deliver by C-section, not vaginally, because the placenta is blocking the exit path. Right? Indications for delivery include labor, life-threatening bleeding, fetal distress, documented fetal lung maturity, so fetus is ready, and 36 weeks gestational age. Right? You need to get the baby out as fast as possible. There's a high risk for placenta accreta, which was the accreta for attachment. Right? So now, because the placenta is in a weird position, it may actually attach a little too strongly, as you can see. Right? So in accreta, the placenta attaches to the myometrium without penetrating it. Extremely common. Right? So it's going to attach to the myometrium because unlike up here, down here is mostly muscle. Up here, there were other things than just muscle. Right? So it can attach to the myometrium. Increta goes into the myometrium, and percreta perforates through the myometrium into the uterine serosa. So here you might see someone with placenta accreta, and that's an answer choice, right? They might ask you, what is the mom at risk for? She's at risk for placenta accreta. Vasa previa, fetal vessels crossing the internal os, preterm delivery, and recurrence risk is, of course, relevant. It can occur again in the next pregnancy as well. Last thing here, vasa previa, which we just looked at, right? Velamentous umbilical cord insertion or bilobed placenta causing vessels to pass over the internal os. Multiple gestations, in vitro fertilization, accessory placental lobes, single umbilical artery, placenta previa, and low-lying placenta are all risk factors for vasa previa. This is also painless at the painless bleeding at the rupture of membranes with fetal bradycardia, because again the fetus is not getting enough blood. Transvaginal ultrasonogram with color Dopplers will show vessels passing over the internal os. You'll immediately be able to see the blood vessels not being where they're supposed to be. Management, well, acute bleeding is an emergency and you need to do C-section and get the baby out because there's no way you can stop that rupture that can occur of the umbilical cord. Diagnosis before bleeding, then you do the steroids again to make sure you can mature the baby as quickly as possible so that you can do C-section and get the baby out. The number one and really bad problem that can occur here is just the fetus can bleed to death, especially if the fetus decides to grab and rupture its own umbilical cord, which is very much possible. All right, so fetal exsanguination, and that's basically it. So let's take a look at this question right here. 29-year-old woman, first pregnancy, 33 weeks gestation, is an inpatient on the antepartum unit for management of known vasa previa. Right, so good age, first pregnancy, 33 weeks gestation. She has vasa previa, so the blood vessel is filamentous, it's compressible, it's squeezable, it's rupturable, and is visible through the cervix, like this. Right? So you can see, you could clearly see the difference. This is a much better picture than the one I had on the other book. Normally, all the blood vessels go into the umbilical cord, which is full of Wharton jelly, so it's safe. Here you can see the blood vessel sticking out. It's not inside the Wharton jelly. Right? This portion is sticking out. It's sensitive, it's rupturable, it's unprotected, and it's squeezable. So that's vasa previa. And when that does occur, you can see it through the cervix right there. Right? So that's really dangerous. This is another case scenario where, of course, you would not want the baby to come out in this direction. You would do a C-section, because if the baby comes out in this direction, the baby's going to tug these vessels out and rupture it, leading to a lot of bleeding for the mom. Right? That's going to be very bad. So she has vasa previa. They're being nice to you in this question. They let you know. A few minutes ago, she had rupture of membranes with leakage of blood-tinged fluid. She has no contractions or heavy vaginal bleeding. That's kind of bad. She should have contractions. Right? Why would there be contractions? Because the baby is going to be responding to the fact that there's a problem here. Right? The pregnancy was the result of in vitro fertilization. Right? So they just told you right here that IVF is one of the major things that can lead to vasa previa. And has been otherwise uncomplicated. Fetal growth ultrasound performed yesterday revealed a cephalic fetus with an estimated fetal weight of at the 50th percentile and a normal amniotic fluid index. So the BPP, the biophysical profile that they're trying to tell you here, is good. Things are looking pretty decent here. The only issue here so far right now today is no contractions. Temperature, blood pressure, pulse, fetal heart rate. Everything's normal except the fetal heart rate. The fetal heart rate is bradycardic. Remember that normal was, I like to say 120 to 140. The book teaches, I think, 110 to 160 or something. Either way, 100 is low. Right? The uterus is non-tender and has no palpable contractions, which is really weird. What is the best next step in her management? Get the baby out. Right? If the baby is not responding with contractions and is bradycardic, then at least we know the baby's alive because the heart rate is there. Baby is alive. Baby's not responsive. We need to get it out. Make sure the baby's okay. Right? So emergency cesarean delivery, and of course cesarean delivery, not vaginal delivery, because as I said, if you do vaginal delivery, you're going to pull these vessels out along with the baby's head, and the vessels are just going to wrap around the baby and get pulled out, and you're going to make the mom bleed to death. Other people chose some other slightly respectable answer choices. This one was respectable. 20% chose betamethasone and magnesium sulfate. However, it loses a little bit of respect in the sense that betamethasone alone may have been a respectable answer choice. But magnesium, why would you give magnesium? She doesn't have hypertension. There's no preeclampsia here, right? Betamethasone makes sense because we need to give for fetal lung maturity, but this baby is not really responding. Betamethasone isn't the key thing right now. The key thing right now is to get the baby out because the baby has no contractions. They told you that twice in the question, right? No contractions whatsoever. So that's already kind of concerning. 10% each chose do a biophysical profile or prophylactic latency antibiotics. Not really respectable. They already did the biophysical profile. Right? We don't need a biophysical profile now because we're also seeing there's no contractions. So it would be a failed non-stress test. All right. And then prophylactic latency antibiotics. I mean, what are we doing antibiotics for? This is not intraamniotic infection. There's no infection. We know what the problem is. The question told you already. There's vasa previa. Normal fetal vessels travel in the umbilical cord surrounded by Wharton jelly that protect them, like that. Vasa previa is an aberrant condition in which the fetal vessels overlie the cervix, surrounded by only thin fetal membranes, making them prone to tear and rupture of membranes or contractions, like that. Not protected by Wharton jelly. In vitro fertilization was her risk factor. Because fetal blood vessel volume is low, fetal demise is rapidly possible. Thus, immediate delivery is necessary. She probably has a ruptured fetal blood vessel, evidenced by the leakage of blood-tinged vaginal fluid and fetal bradycardia, and the lack of contractions. Right? So that's really all this question was. Great question, very straightforward. We talked about placenta accreta already, which of course is something that can occur, as we saw here in placenta previa. If the placenta is not where it's supposed to be, it can also attach too strongly. Here's a question of placenta previa. 29-year-old woman, third pregnancy, comes to the emergency department due to sudden onset vaginal bleeding that has soaked through her clothes. Right, so 29-year-old is good age. She has vaginal bleeding. They didn't say how into the pregnancy she is, but she has vaginal bleeding, and that's really bad. She has had inconsistent prenatal care, which is also very bad, very irresponsible of her, And she says she's about 8 months pregnant. So she doesn't know for sure, but okay. She has had some non-painful contractions. 4 years ago, she had a low transverse cesarean delivery. So her previous delivery was cesarean, so this one's probably also going to need to be cesarean. She smokes. Very unresponsible mother. Blood pressure is low. Pulse is high, so she's in some level of shock already. Fetal heart rate is good though, 150. Right, so with moderate variability, accelerations, and no deceleration. So that's excellent. That's perfect. So the baby is doing well, thankfully. Right. The accelerations are indicative of the fact that the baby is responding to the stress that's happening, the distress that's happening. Tocodinamometry or tocodinamometry, however that's pronounced, shows irregular contractions every 10 to 15 minutes. What is the most likely diagnosis? Well, we're getting a lot of contractions because the baby is really distressed. Now, what could be happening that would cause these kinds of things? Well, if she's bleeding this heavily, right, then it was respectable. It was definitely respectable for 25% of people to choose placental abruption as an answer choice. However, placental abruption, remember what that did? It took the placenta off of the mom. It took the placenta off of the mom so that the placenta was no longer bringing any life support to the baby. So then at that point, the baby would not have a good fetal heart rate with accelerations and no decelerations. That would not occur. So the only way to really pick the correct answer between these two answer choices here was not the mom's presentation, but more so based off of the baby doing well. If the baby is doing well, then you definitely have a placenta that is doing well, but the placenta must not be attached at the right location. Right? This is why I chose this question here, because this was excellent. This is a very well written question where the mom's scenario doesn't tell you exactly what the problem is. There's one thing though that does kind of give away the correct thing, but most students miss it. The one thing is that placental abruption, just from the word abrupt, you can tell it doesn't sound very pleasant. Placental abruption is very painful. Right? We said that here. She, in the question, has painless bleeding. She has vaginal bleeding and non-painful contractions. She never mentions she has very painful bleeding. It's not mentioned, right? It's non-painful bleeding. Safe to assume that. So all of that together, placenta previa, right? The placenta must be something like this, and now it's just kind of detached and not detached, but messed up, and it's bleeding, and it's all coming out, right? Coming out like crazy. But the placenta is also working and keeping the baby well, so that's why you see a good fetal heart rate. And this question here, this one is actually placental abruption, so we can wrap it up with this question, where people were definitely very confused. So I love this question too. You can see 20% chose placenta previa, 30% chose vasa previa, both which are supposed to be painless, and different presentations as we saw today. So this is a 36-year-old woman with her third pregnancy at 29 weeks gestation, comes to labor and delivery due to clear vaginal discharge. So that's pretty bad because it's really early, 29 weeks, right? She has had increasing non-malodorous discharge for the past 2 days with no vaginal bleeding or contractions. No vulvovaginal pruritus, dysuria, or hematuria, so you know it's not maternal infection. She has been treated multiple times during this pregnancy for symptomatic bacterial vaginosis, which is very common, so no big deal. You know, that means absolutely nothing. She's okay. She has no chronic medical conditions. Prior pregnancies ended in term vaginal deliveries. Okay, so previously she's all had vaginal deliveries. She doesn't do any drugs or smoking. Her vitals are looking okay. Fetal heart rate is also okay. Right? Uterus is non-tender and has no palpable contractions. That's kind of not okay. So today she's already got the rupture of membranes, but then there's no contractions. That's kind of weird, right? Speculum exam shows clear fluid in the posterior fornix that increases with Valsalva. Microscopy shows, so we're going to highlight the speculum exam in case we need to come back and look at that. Microscopy shows ferning and squamous epithelial cells with no stippling. Ultrasound shows a cephalic fetus, an anterior placenta, and minimal amniotic fluid with an amniotic fluid index of 3 centimeters. She is at increased risk for what complication? So they just told you a couple things here, right? They're kind of telling you somewhat of the fetal biophysical profile. They're also mentioning these weird squamous epithelial cells. What's actually happening here? And then there's this concept of this ferning thing, right? Why is microscopy showing ferning? What is that supposed to really mean? Well, basically, what it looks like is happening to her is she's having, because the question stem, remember what the question stem is about: vaginal discharge, clear vaginal discharge related to pregnancy. So most likely, and we're going to see this topic later on, she's having premature rupture of membranes, and that's what this was about. So now with premature rupture of membranes, what is she at most risk for? So this most risk for, she is at increased risk for what? This risk question is usually one of the most difficult questions. That usually comes from tables like this, where they're talking about this section, right? What are things that can occur? What is she at risk for, right? So now in our patient, the correct answer was placental abruption, not placenta previa or vasa previa. First of all, placenta previa and vasa previa are not things that you're at risk for. Those are things that occur. They're not something that can occur because you have a risk for it. It's a thing that just occurs, like your placenta already attached at a bad place. It's not that something can happen and then the placenta moved and attached to a bad place. Like just logically speaking, even if you don't know any medicine, but you understand the definition of these three things, logically speaking, how could you be at risk for placenta previa? You can't. There's no way you could be at risk for placenta previa. Placenta previa is just something that happens to you, right? Same for vasa previa. Vasa previa has to just happen. It's not something you're at risk for per se. The only thing that we saw, was that people, like, the other way around. All of these things we saw were other way around. Like vasa previa is something that puts you at risk for other things, but nothing really puts you at risk for vasa previa. The only thing we saw were, and what they're really focusing on is this thing here, right? Risk factors. So we don't need to really worry about any of these things because our patient is already pregnant. She's already got everything going. So that's not what we're looking for. Like this topic of risk factors get tested in such an interesting way that people often get very confused because no one really tends to remember all the risk factors for any kind of case scenario, right? We just saw a question earlier where in vitro fertilization puts you at a risk for having a vasa previa, but in this patient, everything is fine. Everything is just fine. So there's no way that she's now at increased risk for having placenta previa and vasa previa. So the only thing that can happen from here on, now that everything is fine, meaning that the placenta is correctly attached at the good location, is placental abruption. That maybe she's at increased risk for placental abruption due to all her issues, and this explains why. So her vaginal pooling of nitrazine positive fluid that causes ferning on microscopy is consistent with preterm pre-labor rupture of membranes, PPROM, or rupture of membranes at under 37 weeks gestation before labor onset because she has no contractions. Right, so PPROM is a very high yield topic, just like PROM, premature rupture of membranes, but this is even earlier than that. This is preterm pre-labor rupture of membranes, right? So this is too early. As we know, she's only 29 weeks gestation. She doesn't have any contractions. Risk factors include PPROM in a prior pregnancy, antepartum bleeding, GU infections, and particularly bacterial vaginosis. So having bacterial vaginosis puts you at risk for PPROM. Now, her bacterial vaginosis was really bad because she had treated multiple times. If it was once, not the biggest deal, but multiple times, she must just not be practicing very good hygiene. Right? That's why she's getting repeated bacterial vaginosis. Right here. So a common complication is placental abruption, a premature separation of the placenta from the uterus. Placental abruption can occur because decreased amniotic fluid volumes, like hers being less than 5, which is a thing we learned about from the biophysical profile, leads to uterine decompression. This causes maternal decidual vessels to shear, resulting in bleeding and separation of the placenta from the uterus. As the abruption enlarges, patients are at risk for fetal hypoxia and DIC in the mom. Additional complications include intraamniotic infection, preterm labor, and umbilical cord prolapse. Due to the risk of these complications, patients with PPROM require admission and management. Right? You admit them and you monitor them, do regular ultrasounds, and make sure you keep the baby well. Pre-prom does not affect placental attachment or location because both are established already, right? Established prior to rupture of membranes. She's at the point of having rupture of membranes, so there's no way, like, at the stage she's at right now, nothing can put her at risk for placenta previa or vasa previa. Her placenta and vasa are already established. Right? Greatest risk factor for placenta accreta, which was probably another answer choice, is prior uterine surgery, or of course the placenta being placed in the placenta previa area. Vasa previa develops during placental attachment and is not a complication of pre-prom. Vasa previa can occur during attachment in a patient with in vitro fertilization. Right? So that's it for there, and then in our next video we'll continue on tomorrow with intrauterine growth restriction.